Well, every day here on your 5 News First at 4, we've been welcoming local doctors and medical professionals to discuss the COVID-19 pandemic. Today, we are joined by Dr. Randy Maddox. He is the medical director at UAMS in Little Rock. Doctor, thanks for being with us this afternoon.
Good evening. Thank you for having me.
First, if you'd be willing to tell our viewers what you do at UAMS and how that's changed in the last month or so as COVID-19 has continued to spread across the state.
Well, we're doing basically what we always have done. We rule out emergencies. But what we found is more people are coming in with cough, congestion, upper respiratory type symptoms that we're having to sort out whether or not that's allergies, asthma, or COVID or suspect COVID. So we're we're on our toes to recognize those symptoms and try to risk stratify those patients as in low, moderate, and high risk. Of course, part of our screening process is to ask if they've been out of town or out of the country, especially to those high-risk areas, New York, Los Angeles, Chicago, Detroit, those kinds of things. And we assign a risk category to them, and we evaluate them for their illness.
We are back now with Dr. Randy Maddox. He is the medical director at UAMS in Little Rock, and we're fighting with technology this afternoon, but we appreciate your time and joining us. Let's talk real quick. We were talking before our break about the risk factors and how you are putting people in different categories for risk assessment. Is that something that's being done statewide?
It's my understanding, yes. The governor has asked that that people that have traveled out of state specifically be characterized at higher risk. He's wanting some people to be self-quarantined for up to 14 days if they've been to New York and New Jersey, several of those places. But most emergency departments are risk categorizing patients.
Okay. We've talked throughout this pandemic about the curve that we're seeing and the efforts to flatten the curve. When do you expect us to get to the peak of that and past the peak of the virus in the River Valley and in Northwest Arkansas?
Well, from the mathematic calculations based on what we've seen in New York and Washington State, around April 23rd is supposed to be the peak week. What is, I don't want to give people a false sense of security. We're about 1,000 or more patients down than where they expected us to be. We were expect to have over 2,000 or 3,000 people infected by now, but we have 946 confirmed cases currently that you mentioned. We have flattened the curve. The idea is to keep people at home. If you're sick, stay at home. If you're out in the public, according to the governor, wear a mask and 6-foot distance yourself. Social distancing is very, very important in spread of the disease. You can spread the disease just talking to someone. So be very, very careful.
And I know I've had people ask, why should I wear a mask if it's not protecting me? Can you explain a little bit about how that works and how you wearing a mask protects someone else and then vice versa?
Well, it's kind of one of those things in healthcare. Are we protecting ourselves from the patient or from each other? With COVID-19, some people do not have symptoms, or they may have very minor symptoms. So it's best just to wear a mask, and that protects you from the droplet spread. However, if you wash your hands, keep social distancing, that seems to help. But please wear a mask, as the governor states, in public, and any mask will do. To keep the droplet spread. If you happen to sneeze, that can spread particles everywhere. But if you touch surfaces, you're still at risk for getting the disease. You must wash your hands.
Talk a little bit about the stream of patients. Are you still seeing a steady stream of patients that are being screened and then potentially even tested for COVID-19? Has that slowed down at all? Where are we in that process?
It seems to slow down over the weekends, but we're still having quite a few patients come through UAMS drive-through screening. It's at no charge to the patients. They come in, we risk categorize them, risk stratify them. We decide at that point to test them. If they're very high risk or having symptoms, they're sent to the emergency department where we evaluate them and do further testing, like excuse me, like X-rays and lab. We try to keep people separated that aren't at COVID risk in a certain part of the ERs, but we want to try to get people straight back into a negative pressure room, get them treated as quickly as possible. We have seen an influx of patients, again, a steady stream. It has not lightened up at all. We're still getting a bunch of people with flu-like symptoms, cough, congestion, runny nose, fever, myalgias, those kinds of things that you see with a flu.
Yeah. You mentioned that negative pressure room. What does that do and how does that help a patient? Doctor, can you hear me? All right, looks like we're having some more technical issues. We'll try to get those sorted out for you and be back in just a moment. All right, back now with Dr. Randy Maddox. He is the medical director at UAMS in Little Rock. We've been talking about the COVID-19 pandemic, also fighting through some technology issues, but we appreciate your time. Thank you for being with us this afternoon. Let's go back to the question that we froze on before, which was talking about the negative pressure rooms and how that's able to help treat patients who have COVID-19. Talk about how that can make a patient's symptoms hopefully better.
Well, it doesn't really do much for the patient. What it does is take the air circulating in that patient's room and goes outside. It only keeps the air circulating in that single room.
Gotcha.
And keeps the person from COVID from spreading their virus to other rooms with, air conditions they pull from different areas, and it recirculates. This circulates in one room and goes outside.
Okay, so that obviously protects then other people with this being an airborne virus.
Absolutely.
Okay. Talk through the testing process for people, especially people that might end up in one of these drive-through testing sites. What will they experience when they go through that process?
What they'll be asked, we'll categorize them as high risk, medium risk, or low risk. Low risk, we'll likely send them home. We're prioritizing current testing to patients with high risk or healthcare workers. And symptoms will be fever, cough, congestion, shortness of breath, low oxygen level, shortness of breath with activity, and then coexisting diseases like diabetes, hypertension, cigarette smoking, overweight, just to mention a few. And then we will send those people for testing. Whether or not we do in-house testing depends on if you're admitted to the hospital. Those admitted will get an immediate test that has a turnaround about 3 or 4 hours. Those people that are moderate at risk will be sent home, and we'll do a swab, and we will call them daily until the test comes back. Sometimes it takes 4 to 7 days, but we will call them daily to check on their symptoms until the test comes back, but somebody will be in contact with them.
Okay. For people that do end up hospitalized with COVID-19, we know there's a 20% hospitalization rate. Some of those people end up on ventilators. What is kind of an average length that someone may have to be treated with a ventilator before they can be removed and hopefully have recovered from this illness?
Unfortunately, the ventilator rates are at as long as 21, 30 days.
Wow.
It is one of those illnesses that requires high flow oxygen pressure. We're doing some manipulations. We're trying to, with current evidence out of New York, we're trying to prevent people from being intubated and being put on the ventilator. So we're using some high flow oxygen. We're putting people on their bellies to oxygenate them. We're trying to get a few things done to prevent from absolutely having to intubate them. But again, once people are intubated, that virus just goes havoc through the body. And it's uncertain whether the virus is causing the problem or your antibodies or immune system fighting the virus causes problems. It's probably a combination of both. But those people are intubated for a long period of time. 21 days is the maximum I've heard in Arkansas. So.
Wow. When you say that, obviously that's pretty scary to hear that kind of number, but yet these people are then recovering, and some people have been able to walk out of the hospital and walk home with their families. How does the body heal itself even when it's fighting so hard against a virus like this for so long?
Just part of your natural immunity, along with some special things. We're given IV antivirals. We're trying a few things that help the body's ability to fight it off. But, it just depends on your comorbidities, how good a shape you're in, and whether or not you have diabetes or hypertension or have had any kind of respiratory illness or cigarette smoker, those kinds of things, as to how quickly you recover. It does affect young people. It does affect people that don't have any comorbidities. It's just an odd disease. It's one of the worst ones I've ever seen.
Wow. What are some of those medications that you're using on patients who are hospitalized and on ventilators? And is that different on a case-by-case basis, or are you trying everything with every patient?
Well, I think they pull out all the plugs, certainly for people that aren't responding to regular therapy, and they're given IV antivirals. And we're using Plaquenil for some of those, hydroxychloroquine that you hear in the news and the president talk about. Again, that is on a case-by-case basis under the direction of infectious disease, because it is not without its problems. It can cause a great number of issues and make your condition worse.
Wow. We did get some viewer questions that we wanted to ask you quickly. Carol asked us, will the warmer weather put this virus to rest? I know that's been a rumor that's out there, and people say that happens with flu season. Is that something that will also be mirrored with COVID-19?
That's something that's been implied, but you have to look at the people in California, Southern California, where it's warm all the time. they're still having outbreaks and still having an upkeep. I suspect that warm weather, again, the virus doesn't live very long in warm temperatures. I suspect the warm weather will contribute to decreasing the spread of the disease, but I'm not an expert in that area. That would have to be from the health department, but it's my understanding that it could help.
Sure. You're on the front lines. You're seeing these patients who are fighting this and are having very severe symptoms. Are there any moments of hope? Is there something that you can share with viewers that you've seen positive that has brought good news through all of this?
Well, positive things are the community's pulling together. We have physicians and nurses that are on the front lines. As you know, there are 134 healthcare workers that are at risk or are under investigation, and actually 16 physicians that have COVID. We just cross our fingers every day, hope we do the right thing, keep our safe distance, take care of people, do the things we've always done, but try to protect ourselves with gowns, gloves, masks. We're trying also to do some different technologies with telemedicine, but all those things seem to help. There is some light at the end of the tunnel. Hopefully we can get some different treatments that come out of this. We will land on some treatments that work. We're doing everything we can to try to fight the disease and make everybody aware of how serious it is. Again, this is not just your plain flu. This is a deadly virus.
What kind of feedback have you gotten from some of those patients and maybe even their families that you're treating? Have people said that they didn't think it was so serious until they've been impacted by it?
Yes, we've had several patients come in that have just kind of a slight cough, and their main symptom was they just didn't have the energy anymore. They had poor taste, which seemed to be a common finding. The taste is gone, sinus congestion, pain behind their eyes, sore throat, those kinds of things. And they didn't realize that, oh my gosh, I have some of the findings that I just thought it was allergies. Mm-hmm. And I've been around every family member and I have risked and spread this. But they're at relief when we tell them that, hey, it likely is not COVID or it is COVID. So we can get them treated and get them risk stratified and get them, back to a normal lifestyle instead of being, quarantined.
Sure. We have heard over the last month or so, obviously, there is a limitation of testing. Some people are showing symptoms and they're not able to get tested. In the perfect world, would you have a lot more tests, or do you feel like you have the information and the data you need from the current testing levels?
Absolutely. We would want as many tests as we can, because currently the health department is showing about a 6.8%, somewhere in the 6% range of the people they test are positive. Previously, we were at 18%. So you need to have the denominator big enough to know how prevalent it is in the community. In Louisiana, they have a 45% positive rate. It's hard for me to believe that. It sounds like they're not testing enough people. But again, the testing is limited based on the reagents, based on the...
All right, we're having technical issues there, but this is perfect timing. We'll be right back after this break.